Hello, I'm Pierre Nicolo. I'm going to talk to you about vascular complications following filler injection. And this is really due most of the time to an injecting error, technical error. And so we have to know very well the anatomy in order to prevent this kind of trouble. This is a really terrible case of a 7-year-old boy that was injected with some penicillin in the femoral artery. And you see the typical livedo following these injections and the blockade of vascular bed, which unfortunately in this case led to the death. Now, anatomy of the face, vascular anatomy, is a problem because you can see on the sketch on the left that it is shown a fairly straight course going underneath the muscles. Unfortunately, this is not true, as you can see on this dissection, one of them from Philippe Questemont from the Singapore meeting, but there are more and more of these dissection courses, especially at the IMCAS. That shows that the anatomy of the facial artery is extremely variable from one person to the other, but also from one side to the other. So we have to remember that it lays between 4 and 5 millimeters below the surface. And therefore, if we inject superficially, which means in the hypodermal fat, we have to be very close to the dermis, although not intradermal, or very deep, which means at the bone level. The problem that have been described from these direct embolism led to these horrendous problems with necrosis of a lot of areas in the face. And this is due to the extreme richness of the vascular anastomosis, as you see here from the facial artery coming here, sending branches to the lip, this complete circle around the nose, and also the all the anastomosis you get at the glabella, but also from the temporal region across the forehead, rejoining this area, which means that any injection, intravascular injection anywhere in the facial territory, even from the temple, can lead to a problem close to the midline or even inside of the eye. And you can see on these pictures, also taken from a publication by Claudio De Lorenzi, who's done a lot of work on this subject, that you have a blockade here and that ended up with this sort of necrosis, although the injection was done lower in the face. Quite a few loss of sight have been described from injection, mainly in the glabella, but also from other areas of the face, up to, I think, around 32 to 35 cases in the world. And this is thought to be due to retrograde injection from the glabella going right down into this territory. And then when the pressure is released, the blood flow back, frontward will bring back the embolus artery, leading to these complications, as you can see here in a publication from 2012, but there have been more recent publications on that, and you can see on the radiography this occlusion very close to the central retinal artery. And this is a problem which is not very frequent considering the total amount of injection. We did a worldwide survey at the IMCAS, which I presented in 2012, and out of almost 300,000 injections worldwide, the total number of vascular problem was only less than 4 cases per 10,000 injections. And 2/3 of these practitioners who answered that they had seen previously vascular problems, so only 1 case. And the main areas were essentially on the skin at the level of the glabella for 40%, nose and lips. The rest of the face, cheeks, temples, eyelids, around 5 to 10%. And skin necrosis occurred in only 10% of all these cases. So, although it's extremely serious, it's fairly rare, but we are very aware because, as you have seen, the consequences, the anatomical consequences and physiological consequences are extremely important. What causes, as you can see here, well, hyaluronic acid account, if you consider the total number of cases, they account for more than 50% of the cases, but you refer to injection, it's very low, it's around 1 per 10,000, whereas the acrylic gels account for 1.5 to 2%, which is enormous. And this is the kind of trouble that you can see. Necrosis here in the forehead from an injection in the glabella. Here, and as you can see here, it started with a small thing and gradually improved, but also the territory was wider from an injection in the nasolabial fold and the lip. And it has been demonstrated that what would be the major favorizing elements would be to inject too much volume with a very thin needle under too much pressure, which means that if you use a 27 or a 30 gauge needle, you might be within the artery without knowing, or because you cannot retrieve any blood from a 30 gauge needle once your product has been filling the needle. And of course the pressure, if it's over the arterial pressure, systolic pressure, then you will go retrograde within the artery. And also if you inject too much volume, not only a question of intravascular pressure, but also tissular tension and pressure around the vessels, and that would lead to vascular impairment. So it is safer to use cannulas, 25 gauge, avoid very dangerous areas like glabella, or be very, very, very careful. Treatment, well, we know that hyaluronic acids are very rapidly dissolved by hyaluronidase within 10 to 20 minutes. The problem is the speed to make the diagnosis, because we know that within 90 minutes the necrosis will be the destruction, the necrosis, the destruction of the cells will have been achieved, and that imposed to a very rapid diagnostic, and unfortunately in many cases it takes more than 24 hours. Hyaluronidase has eventual potential allergic reaction, you've got to remember that, and the usual dose injected is around between 30 and 100 units through the dilution from the product. Hyaluronidase work as realizing an hydrolysis of the hyaluronic acid, which will lower their viscosity and increase their permeability, and it has also the capacity to treat hyaluronic acid which is already within the vessels, which is extremely important. So really, as a treatment, you have to completely flow the area of injection and all the areas of potential damage with hyaluronidase. As you know, it will don't have to be strictly within the artery. Crash kit, as described by Lorenzi. The Lorenzi hyaluronidase use nitroglycerin paste to augment the local vascular flow and open the collateral vessels. Use aspirin, use warm compresses there also to try to open the vessels, and massage after injecting your hyaluronidase. It's also possible to use, if you don't have nitroglycerin patches, to use the best treatment is prevention, really. So, as we said, injection technique, too much volume, too small a needle, too much pressure. Anatomical knowledge, although it's not totally reliable, but remember, if you stay very superficial, you will be probably safer, especially if you use cannulas. Retrograde aspiration is not always reliable, because most of the product are too viscous to be aspirated, so it's not a complete safety. And beware of scarred areas where the skin is tighter and you can increase the local pressure.